I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor.
We're talking today about a blood test that you've actually probably never heard of. Or if you have heard of it, you've heard of it in a very different context than what we're going to be discussing today. It's not very common that I disagree with reference ranges. So a reference range is when we look at sort of that population data, look at where sort of the 90% of the population sort of falls with respect to a value for a lab test. Generally speaking, we're not wrong about most reference ranges. And if we're going to make changes to reference ranges over time, we make these small modifications. Maybe the exception to that might be vitamin D. When I graduated from school, the vitamin D reference range was about 30 points lower than what we accept to be the bare ass minimum now. So it's interesting, like over time, we do change those reference ranges. But generally speaking, I agree with most reference ranges. And there's always this kind of uncomfortable conversation in the wellness space where we're asking if those values are optimal. And arguably, there are some times where I probably would be dissatisfied with a reference range. Iron is maybe the one that comes to mind where, we let women walk around with, borderline iron deficiency anemia for a long time when we maybe had some whispers of her iron deficiency in her ferritin. And we probably could have acted on it a little sooner. But generally speaking, I'm happy with reference ranges. We don't have a lot of evidence that we should change reference rate or we should change lab values in otherwise healthy people. Even when we see things like glucose and insulin, if you're in the healthy range, pushing you even lower than those numbers that we qualify as being the healthy range don't actually translate into any better health outcomes. And so, for those of you wearing a glucometer right now, or like a continuous glucose monitor, I would argue that maybe lowering your glucose lower than normal is probably not needed, but I digress. But today we're going to talk about a lab test that one, you've probably never heard of in the context of the discussion we're going to have, but two, I'm incredibly dissatisfied with the reference range. And that's both the Canadian and the US reference range where we've decided what the normal value is, and that is actually causing some harm. And people that live within the normal reference range actually have an increased risk of disease. Like I said, this probably never happens. This doesn't happen. So what is the lab test, Jordan? So we're actually talking about uric acid or serum urate. And if you've heard of that lab test before, it's probably in the context of a family member or even you having gout, right? And gout is a chronic inflammatory arthritis that is not happening for the same reasons that we get, say, osteoarthritis, which is that sort of wear and tear arthritis that you may have in your knees over 40, raising my hand. But gout is actually an inflammatory process that happens because of the accumulation of crystals in the joint space. And if you've heard of it before, you probably have this image of like the big red hot toe, right? Or the big hot red thumb knuckle. And that's typically where we'll see gout. It's in some of these smaller joints. It is an acute event, meaning that it's an attack that quite often sends people to the hospital. And the process that's caused gout is that uric acid levels have been elevated to the point where these monosodium urate crystals start to form in their joint space. And I have this and I don't actually know if this was what it looks like, but to me, I have this image in my head of You know, when you see those caves that have like all sorts of like crystals, like salt crystals in them, and they're all spiky and kind of beautiful, but spiky. This is my image of what's happening in the joint in gout. And I'm sorry if you are a molecular biologist and you're like, Jordan, that is not what it looks like. But that's what I imagine it looking like, because essentially the concentration of those salt crystals, those urate salt crystals in the joint, the urate is so concentrated that it starts to come out of solution and it starts to form these crystals. And those crystals start a massive inflammatory reaction in the joint. And this is what leads to this gout attack. Okay, which again sends people to the hospital. But this is not what we're talking about today. We're not talking about gout. So uric acid is not just about gout. And this is kind of where this conversation needs to shift. We used to, or we still do, think of uric acid being solely about gout. And if I say uric acid to a family physician or a naturopathic doctor, they probably say gout back, right? I say uric acid, you say gout. Except that uric acid is elevated in patients who don't have gout. Okay, so just because it's high doesn't mean you have gout as a requisite. And we know that elevated uric acid is actually starting to help us better understand people's genetic risk for cardiovascular disease. So if you've had a cholesterol panel done in the last couple of years and we haven't bothered looking at your uric acid levels, we're actually missing part of the picture that I'm going to argue should be added to give us a more thorough look at your cardiovascular risk profile. So this is a lab test you've maybe heard of, but maybe not. And it's not a lab test that is being routinely run as part of a cardiovascular workup for most patients. And yet, I'm going to show you exactly where this fits and how it offers additional information. And I've talked before about how I'm not giving lab tests out like candy. We need to make sure that we have a good reason and purpose for doing lab tests. I'm not the kind of practitioner that just checks 80 boxes to say, well, let's see what we find, because for every lab test, we're going to get some false positives, meaning that it's flagged, you're flagged and you're fine. We're going to get some false negatives, which means you're not fine and you weren't flagged. And so the decision around making the choice to do lab work with a patient actually should feel more calculated than that. And definitely I've had frustrated people leave my office saying, well, I really wanted my hormones tested, Jordan. And I'm like, yeah, but it doesn't help us. So testing for, you don't search for a needle in a haystack with respect to lab testing. So it needs to add something valuable for us to consider doing it. And I'm going to show you sort of where that urate testing actually causes the greatest benefit and who it causes the greatest benefit in. But I would probably argue that if you are over the age of 40 and we're starting to do some cardiovascular assessment on you, a one-time assessment of your uric acid is quite important. One of the challenges we've faced with gout in the past is that we kind of imagine that gout is the patient's fault. And this actually is being discussed in the medical literature right now, that when patients feel like something's their fault, they don't always get the support that they need because they have a lot of shame around it. And their practitioners treat them like garbage because their practitioner also thinks it's their fault. I've had patients who've had gout who've come back to me and said, my doctor keeps saying quit drinking and I don't drink. And it's like they don't even remember. I'm like, well, first of all, they don't remember because they're seeing 1,000 people. But second of all, we make a lot of assumptions about people who have gout. And one of them is that they're an alcoholic. And so if it's been implied to you and you have gout, or any condition actually, if behaviors have been implied that you do them, it's based on what we think that sort of prototype patient or stereotypical patient would look like if they had that condition. And I've had lots of patients who have liver disease or pancreatic disease or gout where there's a strong genetic component and yet their practitioner still believes that they're an alcoholic, curtained or closeted alcoholic. So the reason that I want you to have at least one uric acid test over the age of 40 is because genetics are actually the greatest contributor to your uric acid levels, not your lifestyle. And in the past, we thought that uric acid was only influenced by lifestyle. So gout was, sort of coined this disease of kings because that's who got gout. And truthfully, at the time, they were the only ones who could afford rich, fatty food. They were the ones who maybe, I don't know did kings exercise? I feel like their step count was probably lower than other people in their sort of kingdom. And so kings got gout and the general population didn't. And so it was this idea that if you got gout, you had this rich lifestyle, because that must be what happened, because that was only kings got gout. But the reality is, when we look at population statistics, your genetics are the primary driver with respect to uric acid. And like I said, not everyone who has elevated uric acid actually gets gout. So why would we screen you? Right? Like, why would we do this test and why would we screen you? And part of it's because this might be one of those little windows, kind of like lipoprotein little a, right? And we'll talk about that lab test at another time. There are some tests that help us try and understand your genetic risk for cardiovascular disease. And uric acid is going to be one of them. It's cheap, it's simple. You're probably going for a cholesterol test anyways, and it would help us see if this number is elevated based on your genetics. Because if it is, we probably want to make some adjustments to your diet and your lifestyle that would actually help lower that number. So how do we know, and who do we test it in? And so it's interesting. Like I said, we can't just do a test for no reason, right? We definitely want to run tests in people that it's got to teach us something new. And I'm sure some of you are thinking, well, if I'm going for a cholesterol panel already from my cardiologist, like, what additional value does this actually have, Jordan? Like, do we need to do this lab test in addition to all the other lab tests that I'm doing? And there was a very, very recent paper that was published. The author's last name was C-U-I. Q-E? I'm terrible at pronouncing words that are not familiar to me. Anyways, this author, CUI, published an article in 2023. So it was actually just published within the last couple of months. And they looked at patients who were super high risk of cardiovascular disease and patients who were low risk of cardiovascular disease, looked at their uric acid, and then they were followed, right? Like we looked at people over time to find out what actually happened to these people. So as you can probably imagine, the people who had high risk for cardiovascular disease, so they had high blood pressure, they had high cholesterol, they had an elevated waist circumference, and they also had elevated uric acid. The uric acid didn't really teach us a lot about that patient, right? So if it was 5 out of 5 lab tests that were elevated in that patient, the value of having that 5th lab test be elevated is really not helpful, right? We already knew that person was at high risk for cardiovascular disease. Every other measurement we did on them showed us that already. And cholesterol and your LDL being maybe the most well-researched and well-validated risk factor for cardiovascular disease, if that's elevated in a patient, like, do we need to do anything else, right? That would kind of be the question. And if we wanted to be prudent and we're trying not to spend the government's money, then we would say, no, we don't really need to do any additional testing on top of that cholesterol panel. We can see that this person in front of us has very high cardiovascular risk. But what they found, and this is where you come in, is that in patients who had no other risk factors, so they didn't have elevated BMI, they didn't have an elevated waist circumference, they didn't have high cholesterol, they didn't have elevated blood pressure, having elevated uric acid independently increased their risk of having a adverse cardiovascular outcome. And we would throw into that pile things like a heart attack or stroke or a clot. So people who were otherwise fine, right? We would not have flagged them otherwise. We wouldn't have picked them out of a crowd, right? If we stood them up, kind of like how you imagine like the old police, where you're trying to pick out the convict, right? And everyone has to stand up against the wall. We wouldn't have flagged this person any other way. And yet in these people, they actually had an increased risk of cardiovascular outcomes, like negative cardiovascular outcomes. And it was substantial enough that if we had run this test at 40 for this person, 45, 50, and they had no other risk factors, that we might actually be able to change their trajectory of their lifetime risk of having a heart attack just by having a conversation. One of the challenges we face, and this is why cardiovascular medicine is like so unsexy, because nobody knows that they're having a problem, and we're generally pretty decent at denial. And it's hard to get patients excited about lowering their blood pressure or lowering their cholesterol when they can't feel it, and the negativity that's associated with those things feels like ambiguous, right? It's like I have an increased risk of this if I don't change, but it's not like you're having the experience, right? It's like we're trying to decrease the likelihood of it happening. And although your practitioner and as someone who spends a lot of time looking at research, if something changes someone's cardiovascular mortality risk, I'm thrilled. But when we look at the day-to-day of a human who's working and commuting and has kids and aging parents, and I say, oh my God, if we did this thing, it would decrease your risk of having a cardiovascular event. It doesn't quite land, right? It doesn't quite land the same. I totally wish that the things that improved people's cardiovascular risk also had some kind of like side benefit that was aesthetic, right? Like if we lower your blood pressure, your skin will be beautiful. I feel like it would be such an easier sell. But instead, we've got these like silent changes that are happening in someone's body. And unless they can get really connected with that risk, or perhaps they've had a family member and they've watched the change or demise of that family member or close friend due to cardiovascular disease, it's really hard. We can't like fear monger people into changing, right? Like no matter how hard we try, we can't actually fear monger people into changing. But for some of you, having a very early indicator that genetically you are kind of in that camp that's going to be at an increased risk of cardiovascular disease, sometimes that's enough for us to make change or start to prioritize pieces or get connected to screening, right? Like if we can identify the people who are at risk, does that mean you're going to get your cholesterol tested more often, or that you're going to engage with that dietitian finally, or that, you're going to get reconnected with your Peloton? Sometimes flagging people can be that sort of first step that we need towards behavior change. It also alerts us as practitioners who we need to pay attention to. Because it's not just you that's, disinterested in your cardiovascular risk. We're generally not awesome at preventative care in conventional medicine, right? We're generally waiting for people to get into the bold, range on their lab tests before we do something. And quite often it's because the thing that we're going to do is give you a drug. And so we don't want to do that too early, right? There's usually not that much value in us over treating people who are well to try and prevent something from happening in the future. So if the only tool you have in your toolkit is drugs, we wait. Right? If the only tool we have is drugs, we wait until you need them. We're not going to use them any earlier. And this is where we get that like frustration that there isn't a focus on preventative medicine. It's like, well, what is your doctor going to do? Their entire toolkit is pharmaceuticals. And I'm not being negative about that. I'm saying we're asking the wrong person to be part of a preventative health strategy, because when they open their toolbox, which whenever I say that, I think about my dad's old red metal toolbox, like literal toolbox that weighed about 1 billion pounds. I always think of that. And then you're opening it, and then the things that you have at your disposal are inside. And it's all medication if it's your doctor. And that's okay, because that's their role, right? But we get frustrated that we're not taking a more preventative approach, but we're asking the wrong person to be that support for us. So we don't want to start medication too early, but when we flag people in a sort of insightful way and with validated lab tests that actually give us some insight about what that person's future might look like, it helps all of us stay more connected to what's going on with you. And so if we can flag you as a potential future cardiovascular patient, not only do you behave differently, but so does your practitioner, right? Suddenly they are going to ask you about your olive oil, or suddenly that 8 pounds of weight you've gained maybe does matter, actually, because it's all like sort of leaning towards this direction. And if we know that genetics have got us a bit more wired for risk, then perhaps each of those small pieces about your health become more valuable, not just to you, but also to your doctor. Which kind of brings me around to the reference range piece. So, like I said, testing serum uric acid, in the past, we only did it for people who had gout, right? Which is not everybody who benefits. We actually, if you're an otherwise totally fine patient who's over the age of 40, I would argue that you should have this test done at least once. If you're a very high risk cardiovascular patient, this number is probably elevated already, and we don't necessarily need to test it to confirm it. But if you're going for lab work anyways, like maybe we want to add this number as something that we learn about you. But I'm just saying I wouldn't be frustrated with your cardiologist if they say no, because if you've got 5 or 6 other risk factors, this is not going to add a whole heck of a lot. Who it's adding value in is people who are otherwise fine, otherwise low risk, cholesterol fine, blood pressure fine, like I said. And so we're finding people who otherwise would not have been found. And that is fascinating, right? Like to take a cheap, inexpensive lab tests that is available, that by adding it to people who are low risk, we're gonna help identify people who are at risk for cardiovascular disease. Like that is just the coolest thing. So often when we innovate in medicine, the thing that we're talking about, like the brand new test that we're talking about, is not that great at finding diseases, is expensive, and isn't accessible. And this is the opposite of all of that. It's cheap, it's easy, it's accessible, and it's quite strongly predicting cardiovascular risk. So I just want to talk a little bit about the reference range here, because I kind of opened the episode by saying, it's not very often that I'm disappointed by a reference range, or that in my opinion, I think the numbers should be different. But this is one of those examples. So when we set the target for uric acid, who were we basing it on? I already told you at the beginning who we were running it in. Who did we base it on? People with gout. So when people have gout, we think that their joint crystals, remember my salt cave reference, we think that their joint crystals are probably starting around a uric acid of 7. And I'm going to use the US reference range because they're just these nice, even numbers. I'll give you the Canadian version of it as well. But we think around 7 is where we start to get that crystallization of those uric acid crystals basically start around 7. So the US reference range takes people up to about 8, because again, not every single person who has uric acid has gout, but it's tolerable up to a level of 8. If you've had gout, we want to push it below 7, because we're like, well, shoot, if you're going to get gout, we need your uric acid to be below 7. And in the Canadian values, 8 is about 480. And for women, we want a slightly lower number than that. We'd like, for men, we're tolerating a higher uric acid level. And for women, we would like it to be a little bit lower. So pre-menopause, your number should be about 390, which is 6.5. And then at menopause, we tolerate the same reference range as men. Women are incredibly underrepresented in the gout literature. And so it's really hard for me to say whether or not I agree with this change. Like at menopause, all of a sudden we think it's fine for you to be the same as men. I don't think the male target is a good number. So I probably would throw both of them in the trash. But we tolerate numbers up to about 8, and in premenopausal women, 6.5 for women, and that's about 390. Okay, so those are the numbers that we tolerate up to in the Canadian and US lab values. So if you go get it tested, you're not going to be bold on the piece of paper unless you fall outside of those numbers, which would be like 9, right, or 500 of uric acid. But remember, who did we make that reference range about? We made it about people with gout. So what does the research say about cardiovascular disease? And this is kind of the fascinating thing, is that when we look at people with cardiovascular disease, guess which number their risk starts to go up? It's about 6, which is about kind of like 340 in the, in the Canadian numbers. So 6-ish, but I just told you that the upper tolerable limit on the reference range is 8. And if you're premenopausal, we're shooting for a 6.5, but at 6 is where your cardiovascular disease risk starts to go up. So does your risk of kidney stones, actually. So there are other things that uric acid is causing. It can be a big contributor to kidney stones. And if you've had kidney stones, you really should have your uric acid levels tested, especially if you don't know the form of your stones. Like if you didn't collect them and have them tested, and you've had kidney stones, you should have your uric acid tested. But essentially, we start to see an increased risk in cardiovascular disease above about 6, which is fascinating because on the paper that you get back from the lab, we tolerate about 8. Okay, and so this is incredibly important because remember, like the original purpose of this lab test was to look for someone who isn't you, unless you have gout. And I'm not excluding you, I'm just saying that lab test was built for someone with gout. The reference range was built for someone with gout. We now have a novel use of this test, which includes screening for cardiovascular risk in low risk people. You have no other risk factors, but we're going to test you. And as soon as you started to get into the 6, 7 range, your risk of cardiovascular disease has been elevated, and it's related to that increase in uric acid. And genetically, you are wired to have more uric acid and have an increased risk of cardiovascular disease. So even though you've never heard of this lab test, I would make a strong recommendation, especially, and I say over 40 as sort of this loose target. Like you might be 40 and not go get blood work done for another year or two, and it's not an emergency. But as we start to evaluate you for cardiovascular risk, wouldn't it be nice to add in some of the tests that start to point us towards your genetic tendency towards cardiovascular disease, and start to give you some insight on what you need to be doing or could be doing to support yourself? If you have goals of prevention, right, in your healthcare, which I'm sure so many of you do, otherwise you probably wouldn't listen to a podcast. If you have goals of preventative medicine, there are these small assessment pieces that can be done decades before the big scary consequence of cardiovascular disease shows up that might give you some insight of where to place your focus. It might give you some insight for how much saturated fat should be in your diet, or what should your dominant dietary oil be, or should you really be avoiding those almonds, or should we get those babies back in there? This can come from this increased knowledge around what your risk is. And it's common when I work with women that have a family history of cardiovascular disease, but to them in their mid-40s, it feels like this, abstract concept to be at an increased risk. Like, what does that even mean? And having someone sit down with you and actually break down what does it mean if we say it's an increased risk, right? It's like, it means that compared to other people, the chances of you experiencing a cardiovascular event are higher. And knowing that cardiovascular disease is the number one killer in women, it's not breast cancer, which we've talked about before, it's cardiovascular disease. Knowing that that's the number one killer of women, wouldn't you want to know if you were at a slightly increased risk based on your genetics? I think it's a great opportunity for us to invite conversation with people, to start talking about that preventative aspect with respect to cardiovascular disease. And it's helping to flag some people who maybe otherwise we would not be having this conversation with. And I would love to have a rich heart disease conversation with every single patient. And I would love if practitioners, conventional and non-conventional, had this lens of looking at their patients through the lens of cardiovascular disease, since this is our number one killer. And so based on that, I am really quite in favor of us doing some screening with respect to uric acid so that we can put the things in place that you need to help support your future risk of cardiovascular disease. The last little piece I want to call out here is that there are drugs that lower uric acid, which they are mostly for people with gout. It would be uncommon for us to use a medication for someone with high uric acid who's never had gout, right? We don't usually treat in advance. And using gout medication, it's not clear whether that lowers your cardiovascular risk. Okay, so just because we have a drug that lowers the number doesn't mean that doing that actually helps you. And so where this conversation needs to go is in preventative medicine and talking about nutrition and exercise and the lifestyle that it takes to build a heart healthy plan for you. Because taking a medication that lowers your uric acid, it's unclear whether or not that actually decreases your risk of cardiovascular disease. There's one medication that we use for gout called allopurinol. It does seem to offer a little bit of protection against heart attacks, but not any other cardiovascular risk. And I know I'm getting a bit technical here, but the reason I'm saying that is because if you do get this lab test done and your uric acid is elevated, and we're looking at this through that cardiovascular lens, the answer might not be medication, even though I'm very pro medication. This is that one time that your diet and lifestyle is actually going to outperform the medication that would be offered to do the same thing. I hope you enjoyed that episode, and I love sort of giving you some insights and some language to be able to talk through how to advocate for some of these tests. And the way I would approach this with your doctor is to, right out of the gates, suggest that it's a one-time screening test. So I think sometimes, when we've talked about lab tests being used for, sort of special and unique ways, your practitioner is going to be maybe skeptical that we think we're doing something with this lab test that we're not, right? And we're not going to track your uric acid over time unless it comes back elevated, in which case you should probably track it over time. But this idea that it's connected to, that your uric acid production is connected to your genetics, and that it also predicts risk of cardiovascular disease in patients who have no other symptoms or no other signs. And the goal would be for it to be a screening test at this point, right? That we're not going to repeat it over and over and over again. If your doctor is unaware that it's going to give us some additional information, you can kind of cite that we do know there's a connection with cardiovascular disease with uric acid, even in patients who are low risk when we meet them. So if your cholesterol is low, that's even more important that you have your uric acid tested, because that's who we find, those are the people that benefit the most, are the people that we haven't otherwise flagged for cardiovascular disease. And so if you're coming up on the opportunity to get some cholesterol testing done, I would highly suggest that we add this really cheap lab test to the requisition, just to get a baseline of where things stand with you so that we can make sure that you're doing everything you can to lower your cardiovascular risk. Because I think if we offered you the opportunity to gain some insight into what's going on inside your body, you probably would take it. I know I would. I'll see you next week.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.